Good evening and welcome everyone to the first I-ASPN clinical webinar. We are so excited that you've joined us this evening and this morning around the world. This clinical webinar will focus on regenerative medicine for the spine and joints. And I would like to introduce our moderators for this evening and this morning, Drs. Rita Tolba, Dr. Dawood Syed, and Dr. Timothy Deer. Dr. Tolba, take it away.
I can actually
Thank you very much. So, Tim, you want to start first, please?
I think Dawood's got a few comments to start off. Dawood?
Yeah, well, we're all good morning, good afternoon, good evening, depending on what part of the globe, or maybe good middle of the night to you. This is a really exciting and important event for our organization and our new division of ASPN, the International Division. So Dr. Tolba has been instrumental in his leadership in focusing our efforts on improving education and patient outcomes, not only in the United States as we have with ASPN, but now to kind of broaden our reach and bring that education, leadership, and focus on advanced therapies to the globe. So this is our first program, so I think this is really an important landmark as we start to develop this division beyond just webinars and in-person meetings. So we're really excited about where this is headed. And then I'm going to leave it now to Dr. Timothy Deer, the chairman of ASPN.
Well, thanks, Dawood, and welcome everyone. It's certainly exciting to me to have Dr. Tolba and all of our great colleagues. What an amazing faculty we have today to talk to you about the international division of our society. Really, I think the growth has been tremendous, and whether you're watching this live, and I know sometimes with time zones this could be challenging, or you're watching this on our website where we expect a few thousand people to do so, I hope you have a great learning event today. And I tell you, the faculty we have here are the world experts, and it just really warms my soul to see such great talented people wanting to help each other, which is what we're about. So if you'd like to get involved in the international division, please contact Dr. Tolba. He's leading a group of people that will be the leaders in this area. And the goal is to improve patient safety and efficacy throughout the world. With that, Rita, to you.
Thank you, Tim. Thank you, Dawood. And thank you all the faculty. Basically, we have a great group of faculty. They are leaders in the field of regenerative medicine. As Dawood and Tim said, our goal is to have global audience and members to drive to the I-ASPN, as we serve our mission for education, research, and patient care. And I'd like to first talk about what's we will be presenting today. It's about regenerative medicine of the spine and joints. I'm so excited to have our faculty here. We have Dr. Sudhir Diwan, Dr. George Cheng Chin, Dr. Agnes Sodisca, Dr. Stanley Lam, Dr. Jendi Pen, and Dr. Abdallah Lam. So first, it's my honor and pleasure to introduce Dr. Diwan. Dr. Diwan is we all know him. He's a well-known expert in the field. We all learned from him in different societies. Dr. Diwan is currently the executive director of NYSIP, the course chairman of the NYSIP Pain Symposium. He has had multiple leadership positions in different societies, including ASIP, NANS, INS, and he's a well-known figure in the world of pain. So without further ado, I would like to, Dr. Diwan, please take over.
Thank you, Dr. Reda, for your kind introduction, and thank you, Team Dawood and the organizing committee to invite me to give this the first I-ASPN webinar. I'm going to talk about the Ortho Biologics. Now we understand the Ortho Biologics is based on cellular and molecular components, and that is what promotes the tissue repair. And my focus will be the intradiscal use of this Ortho Biologics. We know that PRP and BMEC has been used for intradiscal use, and there are chances that there are some evidence that it may work synergistically, but we don't have enough evidence yet in the literature. The PRP has shown to be very effective for cartilage, bone, and muscles. However, for the disc is not as good as we like to have it. These products has been described for a long time, but have not been described as the synergistic products for disc use. PRP, as you know, that it's 3 to 5 times your peripheral blood, but when it is more than 1.5 million, then it might actually inhibit the stem cell proliferation. The driving force for PRP use in clinical practice are the growth factors and released from the alpha granules. But not just the growth factors, PRP also has multiple cells, macrophages, monocytes, fibroblasts, etc. One of the things that PRP does is when you inject the PRP into the disc, there are 2 ways the growth factors are released. One is the quick release, and then there is a slow release. The slow release is based on the fibrin, which is the final product of the platelet cascade, and that releases the products very, very slowly to provide the growth factor to the in the disc. This is a short list of the all growth factors that help to regenerate and heal the disc. The platelets has to be activated. The insulin-like growth factor, fibroblast growth factor, and epidermal are the one that repairs the skeletal muscle and differentiates the and helps differentiation during the repair. The growth differentiated factor and bone morphogenic factor is very, very important. It's the osteoprogenitor that helps for the bone growth and chondriocytes. I think this is very important for the end plates to heal, because if you have a end plate degenerated or fracture, the repair would be done by these growth factors. So the growth factors are very important. Now, the main problem that we are going through is the lack of standardization. We have multiple systems in use, and all systems claim to be the best in the world. And because their systems are different, gravitational or some closed systems, and then SCP, autologous conditioned plasma. I have used all of these systems, and I have not really seen much difference into one system over other. But however, because of the different system, different harvesting techniques, it's very, very difficult to understand which product is best. Right now, I'm using the SCP system, which is a single spin, and it's a 2 series where you can get the PRP with some scaffolding proteins. It doesn't give you a buffy coat, so the PRP number of platelets are very low, but also it gives you the protein that you require for the scaffolding and for the regeneration of the extracellular matrix. So I'm not 100% sure whether I'm doing the right thing or not, but that's what I'm doing lately. The studies have shown a few years ago, the ACIP did this, published these guidelines and reviewed the literature, and the evidence shows that there is a level 3 evidence for intradiscal PRP and stem cells, rather the mesenchymal cells. The evidence is very poor for lumbar facet joints, lumbar epidurals, and sacroiliac joints. And the reason why the evidence is very low is because that there is a very low quality studies, and there is a very above reporting characteristics, and that's why we don't have a high level of the evidence. Now, as looking at the mesenchymal stem cells, we all know that these cells are the multipotent cells. But one of the also other properties that we must appreciate is the paracrine properties. It secretes the extracellular vesicles, exosomes, and microvesicles. And exosomes have becoming more and more popular as cellular product for regenerative medicine. Has been used for the musculoskeletal condition, rather joints and muscles, has not really been used that frequently for the intradiscal purpose yet. We don't call it mesenchymal stem cells anymore, which was given the name by Dr. Kaplan in 2006. Now we call it medicinal signaling cells, and that's because the pericytes, which reside in the subcortical space of in the bone marrow, you extract them. Those pericytes actually stimulate the native mesenchymal cells, and those mesenchymal cells then construct the new tissues depending on the native stem cells. So actual work is done by the native cells, which are activated by the pericytes from the bone marrow. Now, if you look at the bone marrow product, you have a hematopoietic cells, mesenchymal cells, and these are mainly the very important cells that we have in bone marrow that we don't have in PRP. But there are also other cells, precursors and proteins. A2M. A2M is I'm very big supporter of A2M because that is what is a broad spectrum protease inhibitor, preserves the cartilage. For BMAC, the hematopoietic cells, which gives the origin to cell lines, platelets, RBCs, WBCs, etc. And the mesenchymal stem cells gives rise to fibroblasts, osteoblasts, and all other cells. So these are the two cells are very important in the BMAC. Now, when you do the BMAC, and if you're looking at the really success of the outcome, you also have to learn how to precisely and skillfully harvest the bone marrow, because the bone marrow you harvest for bone marrow transplant is not same as the harvesting for the mesenchymal stem cells. So you have to use the posterior superior iliac spine, which is the best place. Use smaller syringes, smaller volume, and that will give you a better colony count as compared to larger syringes. Now, this one study I want to talk about, this is a study came out in 2017, a series of 26 patients and a 3-year follow-up, and they looked at if any patient has, there's all this 26 patients were all in the list for the surgery. They also looked at this colony counts and also the cell count progenitor cells. And out of at 36 months, only 6 patients went for surgery. So 20 patients did very well with significant improvement in ODI and VS score. So this is very, very helpful. And in this cell count, they also saw the CD34 plus count of 1.8 million. This is very important because CD34 is the marker for the hematopoietic cells. So when you look at the PRP and the BMAC, there are some growth factors are more in BMAC and some are the same. However, the anti-inflammatory component, cytokine interleukin IRA, is much significant amount in BMAC as compared to the PRP. So is PRP better than, is the BMAC better than PRP? Some studies does show that the B fibroblast growth factor is higher in BMAC, but there's no difference in other growth factors. But BMAC does have close to 2 million count of CD34, which is very important because marker for the hematopoietic cells. The other study also supports that BMAC is better than the PRP. This is also looking at the PRP when it's mixed with the bone marrow. It may actually have a synergistic effect and should be used. There is only one animal study that shows that when the PRP plus bone marrow was injected for degenerative disc in an animal model, the combination did better than the PRP. So the take-home message is that it's not just what to inject is important, but where to inject and how to inject is equally important to have the better outcome. Because if you are injecting into the disc for degenerative, is not the same as for the herniated disc. And also, when you are injecting the disc at the lumbar disc versus the cervical disc, your plan should change. So where to inject, how to inject, and what to inject. All this together will improve the outcome of your procedure. With that, thank you for invitation, and I'll stop my presentation here.
Well, that was a great job, Sudhir, as always. You know, I've learned so much from you over the years. And, you know, I just have a really interesting question for you. If you're in, let's say you're in a country where you've never offered this therapy before, and you want to offer the therapy to your patients, or you're in a part of America where you've not had the economic ability to offer it to people because of the ability to pay, just give us a really simple answer. What's the best way to get started with something like this? What would you start off with? What's the most potential cost available option for patients?
Now knowing that not really any significant difference, different systems. If any system which can give me a separation of the RBCs and platelets and plasma can equally give the good results. So I would just go very simple PRP, because if you don't use any expensive kits, then price will go down. And as I said, except the mesenchymal stem cells and hematopoietic cells, the PRP has almost everything what you find in BMAC. So that would be my first way to start. Only difference in PRP is that you might have to repeat it more frequently, but PRP is the way to go.
That's a great answer. That was a great presentation. I have a question for you as well, Dr. Dewan. So we always have a lot of patients asking us about these types of regenerative therapies too. I find that degenerative disc disease has such a broad spectrum. You may have a patient that has, severe degenerative disc disease and has had multiple back surgeries, but then there's someone with very early changes, and then people kind of in the middle. Based on your experience with this and the evidence, when is the right time to select patients for this type of modality? Is it early? Is it when they're not as symptomatic, or is it, very late in the game?
See, for degenerative disc, our goal is to really either prevent the degeneration and promote the regeneration. With that in mind, earlier is always better. Right now, we are getting the patients who are at the end, when everything fails, then they will come. And also because it's a cash payment, so we are very careful in recommending. But as a science, as my experience and what science says, you should really start using when your degeneration is, stage 1, stage 2, to prevent it. Then you will really have, you can push back your 10, 20 years of the symptomatic presentation of the progressive degeneration. So sooner is better.
Thank you.
Amazing talk, Dr. Dewan. My last question is, how much percentage of your patients are like sports medicine or people who are athletes who wants to have this kind of therapy to prolong their career?
Yeah, in my personal practice, the sports medicine is not the mainstay. I have been always working on the spine. So right now, my spine cases for regenerative medicine are much more than the sports medicine. Having said that, I do major joints, shoulder, knee, hips, and ankle, but less of the sports injury and more of the chronic injury.
Thank you, Dr. Dewan. So thank you for the amazing presentation, Dr. Dewan, and I will present our next faculty. This is Dr. George Chang Chin. He's my good friend. He's the director of the Pain Management Center at the Ventura County Medical Center. He's trained in physical medicine and rehabilitation at Northwestern University, and he's did his fellowship in our prestigious Cleveland Clinic Foundation in pain management. Dr. Chang specializes in regenerative medicine with expertise in PRP, bone marrow aspiration, and adipose-derived stem cells. He's an expert and in comprehensive pain management. He's very active in regenerative medicine. So Dr. George, it's all yours.
Thank you, Rita. Dr. Dewan, I don't know if you can still hear me, but that was a fantastic talk, and I agree with him. I think early intervention is fantastic, and to piggyback on the mentioning regarding seeing patients and when to intervene, I see people who are runners, such as avid athletes, and I don't see Tim Deere, but the people who might perform at this level and keep their joints going for the next thousands of miles that they'll run for the rest of their lives, will actually treat them now prophylactically, and also as well as after any major events that they might have. I'm giving a brief talk on tendinopathy. and a quick case report at the end. And tendinopathy is actually the poster child for regenerative medicine. It has multiple prospective randomized controlled trials that utilize this as the model for study. And there are easily 20+ studies that are done all over the world that have shown positive results. So, okay, this is my disclosure slides. I am a speaker for Apex Biologics, and they are a company that makes regenerative medicine supplies. I'm trying to advance my slides. Please, I think, yeah, I don't think it's working suddenly. So very briefly, this is a cartoon diagram of what a tendon looks like. Now on the left side of the screen, we'll see what a normal tendon is. Tendons connect muscles to bones. And the tendon fibrils are tightly packed. It's sort of, imagine like a fiber optic cable. And there's these tightly bundled normal type 1 collagen fibrils, and they're going to all run essentially parallel to each other. And besides having collagen in here, it's going to be in general an avascular and acellular tissue product. Now on the right side, we have what happens when it has degenerative chronic tendinopathy. And so you'll notice that there's increased cellularity. You have myofibroblasts that start growing into it. You have also actually other types of cells that are growing into it, as well as having what are called mucoid changes, where it becomes sort of degenerated and you have, it turns into a mucinous product. Two things that are notable here is that you have neovascularity, where new blood vessels will start growing into it to provide blood flow to an avascular structure, as well as you actually have C fibers that start growing into the tendon as well. And this is something that shouldn't hurt, start developing chronification of pain. Can you go on to the next slide, please? So this is a graph from a systematic review, kind of showing all the complex changes that are occurring when someone develops tendinopathy. You'll notice right in the middle of our screen, we have what it says, cytokines and signaling factors. And you'll notice there's upregulation, release of all these factors, insulin growth factor, platelet-derived growth factor, vascular endothelial growth factor, et cetera. And these are some of the ones that Dr. Derwan had mentioned previously. These are released such that the body is trying to heal itself. On the column directly adjacent to it, you'll also notice, though, that we have upregulation of COX and glutamate, substance P, NMDA receptors, et cetera. And these, as you all know, are indicative of the chronification of pain. These are the things that cause wind-up and allodynia. And so you see that there's a potential for the body to take something that could be healed, and that's an acute problem, and turning into a chronic problem. Now, on this right-hand side where it talks about enzymes, you'll notice there's a whole slew of them, and MMP stand for metal metalloproteinases, and these break down collagen fibrils. They break down different types of collagen, and the purpose of this is that when you have an injured tissue, the body has to remodel. And so these matrix metalloproteinases will essentially come in and erode away at the degenerative tissue, such that at some point you have matrix deposition and you have increase of different types of collagen, fibronectin, aggrecan, et cetera, which is where it is on the left-hand side. Now, at some point you have this remodeling, and this isn't just really specific to tendons. This is actually every time you have an injury. If you have a patient who has a myocardial infarction, they survive, this is pretty much the process that they're going to go through. Can you advance the slide, please? Michelle, I don't have control. Thank you. When we take a slide of this and look at it under histologic, under microscope, you'll see that the normal tendon, again, has that same fibril orientation where they're kind of running parallel to each other, although they're a little wavy. It's very uniform. Next slide, please. Next slide, please. Now, when you have pathologic changes, this same images on the previous slide now, you'll see that we've lost that tightly packed compact bundles of the fibrils. On this image on the right-hand side, you'll see that there are vacuoles that have developed. These are holes and tears within the tendon. You have this blood vessel that's growing into the tendon as well. And that's such that we're bringing in blood flow to this injured tissue to help remodel it. Next slide, please. Next slide. So when we look at this under MRI, this is an Achilles tendon. Now, left-hand side, you'll notice that this Achilles tendon has this normal morphology where the fibrils are running parallel to each other, and it's tight and it's compact, and it has the same MR signal throughout. On this image on the right-hand side, you'll notice how we have this grossly thickened Achilles tendon. It comes off the Achilles, it comes off the calcaneus distally, and it immediately sort of forms this bulbous shape, like a potato. And there's mixed echo texture, not echo texture, but this mixed MR signal, and it's sort of pockmarked by these increased and decreased T-weighted signals. Anyhow, so you'll kind of have an idea of what's going on. And this is what's one of the first signs of tendinopathy is actually thickening of it. Next slide, please. So I won't belabor a whole lot of the basic science, but I think this is a powerful and simplistic study that looks at the effects of PRP. Dr. Dewan already talked a whole lot about PRP and MSCs and exosomes, so I won't really get into it. But this is a cool study because what they did is that they took tendon cells that were pathologic, that they retrieved the stuff that was going to get thrown away, and they isolated the tenocytes, which are the mature tendon cells from the pathologic tendon at rotator cuff repair time. And they enzymatically isolated and cultured these cells, and then they added variables such as increasing concentrations of PRP. And they found that these cells, these tenocytes, responded positively to the PRP in a dose-dependent manner, meaning the higher the concentration of PRP, the faster they grew, the more proliferative they were. And in the studies, not this one, but in the studies that they look at what comes out of the cells, the markers for cellular maturity and the markers for that show that there's an anabolic process going on, that they're, again, very much dose and time dependent. Next slide, please. So again, I mentioned that tendinopathy is sort of the poster child for regenerative medicine. And this is the Pierre Boom study, and this is the this was done in the Netherlands, and this is the 1-year follow-up. Now, they followed up these same patients at 2 years. And what they were treating here was common tenon elbow insertion, or extensor tendinopathy. So it's double-blind randomized controlled trial, and they compared PRP to corticosteroid. Next slide, please. So this is the disability arm, shoulder, hand score, okay? And they follow people in this graph up to 1 year. Now, if you have a DASH score, the higher the DASH score, the more disabled you are. So you actually want to have a lower DASH score. You'll notice a few things that are going on. The dark green line was the corticosteroid arm of the study, and the light green line was the PRP line. So although they start at different DASH points, I want you to take note of the sort of trajectory of these lines. Now, there's a more marked downward immediate effect for the corticosteroid arm that you'll notice, but very quickly it starts to sort of dissipate and wane. And if you do these types of procedures, you'll notice that this isn't abnormal for a lot of the types of peripheral joint injections that you might do. The PRP arm does also have almost immediate benefits, not as markedly, but you'll notice what's important here in the study is that the two arms of the study actually cross over at about 12 weeks. And the persistent benefits of the PRP last quite a long time, such that at the end of the 52-week study, the mean dash difference, the mean delta for the two arms of the study are quite significant. That's what's noted on the right-hand side by the two double-headed pink arrows. And if you follow the study at their 2-week follow-up period, these benefits are persistent in the PRP arm. Next study, please. This is VAS, which you're all very familiar with, visual analog of pain score, and it just shows the same thing where the corticosteroids and the PRP arms of this study cross over at about the 10-week mark. And at the end of the study, the mean delta for the PRP, goes from about a 7 pain score to about a 2.5, 3. So I think that's pretty meaningful. Next slide. So very quickly, this is a patient of mine. He's a fantastic guy. He's a professional fighter. We'll have to go back one slide now. I apologize. I don't know why it doesn't work for me. We have to go backwards. If we can go back on the slides. If not, I'll just talk about, he was a patient that was referred to me with shoulder pain. He's located out of Colorado, and he had multiple injuries throughout his life related to sports injuries, jiu-jitsu, football, etc. And he had an MR before he came out to me. It showed that he had supraspinatus tear. He had a slap lesion in his labrum. And when I took a look at him, I obviously saw that he had the supraspinatus tear. He had a lot of degenerative changes in his labrum, arthritis built up on the humeral head as well as within the glenoid. Because of the large pec muscles, it was a little bit difficult to visualize anteriorly, and he also had a chronic AC joint separation. Next slide, please.
All right.
Exposed areas that you can see. Next slide, please.
Okay.
And this is his MRI. So I don't know if you guys can see where my arrowhead is at, but you'll notice on this MRI, he has this lesion that starts at the footprint, the insertional footprint of the supraspinatus, and it sort of has this lightning bolt tear that runs through the intrasubstance of his supraspinatus. The supraspinatus is made up of multiple layers. Imagine like layers of a birthday cake, and so this is actually going through multiple layers of it. I don't know why the slide is advancing on its own, but anyhow, I don't know if we can stop this, but this is his ultrasound of his posterior shoulder. You'll notice on the right-hand side, this is what a normal one should look like. And I can't make the arrow go to where I want you to look at, but there's a few characteristic findings here. And one, namely, is that there's this labrum, and you can see that there's a fissure. The labrum should look like a wedge of a triangle. And he has a few things that are going on here. There's loss of the normal morphology of that labrum. There's a tear going through it, and his humeral head has sort of subluxed due to the instability in the shoulder. Can you advance the slide, please? And under ultrasound, you'll see that this is the same thing. I don't know if you can hit play on those videos, but this is his supraspinatus in that same orientation as the MRI. You notice that same fissure running again from the distal footprint into the intrasubstance of his supraspinatus. On the bottom right, we have, can you hit play on that video on the bottom right, please? Now this orientation is inverted, and so it's left is right and right is left compared to the top left one. And I'm just using the end of this stick to demonstrate where that lesion has mostly healed, and some of it obviously continues to persist. I had put PRP into it and around the lesion, utilizing it like a biologic glue to help get this to heal. I've treated him multiple times now for different various injuries. Many times it's been his shoulders, not always his rotator cuff. But I can tell you that I keep very much in touch with this gentleman, and he's told me that he's, back to competition level in his shoulders. He feels like they're 100%. He's very happy, and he's referred to me many of his families and friends and his colleagues. If you'd like to know more about what I do, I have an Instagram, and there's my website, gccinstitute.org. I'm down here in Newport Beach in Irvine, California. Thank you so much for your time. I apologize for the technical difficulties.
George, great job as always, and I love your social media content, so I encourage everyone to follow you. I have one question for you. I treat a lot of runners and triathletes, and one of the most common frustrating injuries is Achilles tendonitis. It's a very difficult situation for people. Just very briefly, what's your recommendation for that?
So Achilles tendinopathy is very interesting because, so first of all, I'd like to start with the idea that a lot of the regenerative medicine studies for soft tissue, it's much better in the upper extremity than the lower extremity. And one of the reasons we think that is like that is because it's much easier for someone to do relative non-weight bearing in the upper extremity than the lower extremity. And the corollary to that is that there was a recent study where they looked at microfracture for knees, okay? And they put people in what's called an offloading brace. So you're supposed to be non-weight bearing for, I think, 8 weeks anyways, which is like almost impossible for normal people, right? You think about it, we do this procedure and you're non-weight bearing for 8 weeks. They put them in this non-weight bearing offloading knee brace, and the people that I think did that for an extra 2 months did much better. And this was found on MRI. Now, coming back, I'm sorry, this is coming back to your question though, why, Achilles is tough to treat. What I like to do is that depending on what I see, how bad it is, I'll put some PRP. I usually start with leukocyte PRP, and I'll put it definitely around the tendon. I'll go in and I'll dissect it away from what's called Kager's fat pad, which is the fat pad underneath it. And if there's some areas that I think that it's not unreasonable, I'll put directly PRP into the tendon. Now, again, I don't want to make it worse by injecting stuff into something that's already essentially starting to turn into mush. You can put them in what's called a plantar flexion boot for at least 4 weeks, and essentially it puts them off of weight bearing and approximates the tendon, takes the load and stress off of it. And in general, they can do very well, but they have to. It's sort of a strict protocol to get off of it, and it's tough for the types of athletes, people who are like you. People who are like that guy Josh, I told him don't use the don't use the rotator cuff, and he was literally sparring like 3 days later, because that's what he does for a living.
Yeah, we're terrible patients for sure. No question about that. Dawood?
Yeah, that's a fascinating topic, George. I have a specific question for you as well. I've incorporated like percutaneous tenotomy into my practice for patients with with chronic elbow pain, hip pain, those types of things. Is there a role for doing things like percutaneous tenotomies with a regenerative treatment like PRP at the same time, in your opinion?
Absolutely. In fact, a lot of the patients that we see that have these calcifications within the tendon, there's good evidence out there, to be frank with you, where the tenotomy or just needling that calcification itself stimulates healing and is going to be very good. There was a great study at University of Michigan by radiology professor John Jacobson. He's fantastic. He's written books on ultrasound, etc. But they randomized people to percutaneous tenotomy itself, essentially just needle fenestration, poking away at the calcification, versus PRP. And they found that both arms of the study did better. Now, when you add PRP to it, it's going to heal faster. It's going to heal better. Maybe not better, but definitely faster. And this has been shown in publications going in the JAMA New England Journal. It's going to make it faster, and a return to play is going to be quicker. So, God forbid somebody, at the level of Tim Deere comes in and he says, I've got an Ironman in 5 weeks, and I'm normally training, 3 or 4 days a week, if not 7 days a week. We need to get you ready in 6 weeks. The tenotomy itself might provide, good healing in 3 months. If we give you PRP, maybe we can augment that and you know, get you back to training level within maybe half that time.
Great. George, great job. Appreciate
you.
you. That was a wonderful discussion, and I look forward to seeing you in Miami. Rita, back to you.
Thank you, Tim. And before I introduce the next faculty, from the audience, there is a question from Dr. Mahesh Prakash about the question for George is, in case of tendinosis, do you need to inject PRP in the whole length of the tendon? And so how much PRP do you usually use?
Very quickly, you know, you can identify the area where you have tendinopathy under ultrasound, and I would inject very carefully into the area of tendinopathy, but it's very reasonable to inject and bathe the entire tendon around it. So it's called a peritendinous injection. Thank you.
Thank you, George. So now moving on to our next speaker. This is Dr. Agnes Sodisca, is the board certified anesthesiologist, a pain physician. She's very well known internationally. She has over 15 years of experience in interventional pain management. She actually she did her pain fellowship at the University of Washington in the US and has been faculty for over 8 years there. Then she returned, she's now practicing in Budapest, in Hungary. She's heavily involved in the World Institute of Pain. She's the vice chair of Hungarian section of WIP. And also she's the co-founder of Pain School International. And she's not be able to be here with us, but she has a recorded session. So Michelle, we going to play her session, please.
Well, good morning, good evening, good afternoon. Thank you very much for the invitation. So my 10 minutes will talk about the evidence for this procedure in regenerative medicine. It's a bit of a big topic, and I made a short summary for you guys. This is my disclosure slide. I speak for a couple of companies, radio frequency and cryo companies, none of them related to PRP or bone marrow concentrate. I'm a co-founder of Pain School International. I'm on the WIP Education Committee, and I teach for a few societies. I'm going to start with the conclusion slide because it's only really a few thoughts that we can remember from one talk. So the conclusion is that there is good evidence that steroids do not work. There is good, I mean level 1 evidence, but not much, that PRP and bone marrow does work for disc problems. And one more thought or conclusion is that if you understand the actual biomechanics, the reason why the patient developed the pain, you will be much, much more successful. And I also show you a study for that. So this is showing this building after the 1989 Loma Prieta earthquake in San Francisco. The building didn't collapse, but all the windows broke. I'd like you to think of the windows as the discs, okay? Now this is what Japan does. They make earthquake-resistant buildings by cross bracing, okay? Just remember this. So that's one way to make a motion-resistant building. And I think it very much applies for the human body too. A quick review on steroids. JAMA article proves that 2 years of triamcinolone makes knee joints much worse than if you do nothing. Here we have a Lancet study that proves that corticosteroids make tendinopathies much worse than when you do nothing. Just bear it in mind. So be careful. We have more and more evidence, and because of the limited time, I'm just showing you this, but there is so much more that we understand that steroids do not give long-term solution. They make us look good, and then it's the downfall of the patients. Okay? So let's look at the discs. What do we have? We know this. Many of you seen this slide. I don't know who was the first author of this slide, but it's a very smart one. We come up with good therapies for discs. They look good, and then we fail with them. Now we know that if we put PRP or stem cells in the disc, we know it in animals, that you can improve the disc height and you can even make the MRI look better. Now we don't have that much for humans, but we have some. So here you can see what's available for PRP for low back pain patients. We have case series and prospective trials and more case series. They're all positive. Some only follows the patients for 6 months, but they are positive. Now the one I want to point out is this yellow highlighted one, the Tuakli-Lutz study, because they went and did actually a nice quality study. They did lumbar, interdiscal PRP, prospective, double-blind, randomized controlled study. They came up eventually with 3 publications, but it's the same project. The first publication was really, as mentioned, double-blind IRCT, beautiful. The results were so good that, of course, when they went back for the second publication, 2 years after, the patients were no longer randomized. But what they found, that the patients who did get the PRP treatment were doing much better. And then they revisited the question and the patients 5-9 years after the initial treatment, and they found the patients are still doing much better. They essentially included patients, 60 of them, who had pain more than 6 months, easy. They failed conservative treatments, right? It's obvious those are the patients we inject. And they confirmed the diagnosis partly by HIZ, which is the high intensity zone on the MRI. Here is, you can see this little white thing. This correlates with discogenic pain, and it also has an 86% positive predictive value of having a positive discogram. Now let's look at the discogram. You stick your needle in the patient, in the suspect discs. Here I stick it L3-4, L4-5. You immediately see that the L4-5 disc leaks. And this was a young patient with sitting pain, so very clinically very obvious. MRI showed an HIZ. And this is what you saw, or what I saw about 5 minutes later, that even though here the contrast sits in a nice looking lenticular shape, a little later it all leaked out to the epidural space. So 2 annular tears. So this was a typical patient for the Lutz case series, which showed good results, and good results. Now, the benchmark human study is the Patin disc BMC study. It was a prospective study. He did the same thing. He confirmed the annular tear by a discogram, which is the same method. He collected data for 3 years first, and then later he published as well again. But essentially, 20 out of the 26 patients remained enrolled in the study at 3-year point. He lost some to surgery, but many of them were doing really well. This is how well they were doing. They had 67% reduction in the ODI and 73% reduction in the VAS. And this was maintained through 3 years. Now this is important because if you look at the medications, the studies last for 6 months for gabapentin or pregabalin. They don't last long, but the pain does last long. If you look at any other, I would say, mainstream standard treatment, radiofrequencies, the pain relief lasts for a year or 2. And here we have something that we can talk about lasting potentially for years. So let's get back to this. I think, and this is it's not, I wanted to say it's personal, it's not a personal, it's a direction in pain medicine, and many physicians think that way. It's not just me, but it really resonates with me. I think when we do disc injection, we are actually patching these broken windows. We do not fix the underlying problem, which is the lack of the cross bracing, as I showed you. But there is this study by Kirchner. There's a lot of reasons to criticize the study. But one thing is very exciting about it. He injected intradiscal, intra-articular in the facet, and transforaminal epidural injection. His outcomes are amazing. 96% of the patients showed excellent result at 6 months and also on longer term. Now, why do I love this study so much? I'll show you why. But I believe that happens with the patient when they have a discogenic pain. First, usually they don't have discogenic pain. They start with rupturing the ligaments, spinous process is separating, forward pressure going on the disc bulging out, or ruptures. They may have radicular pain or may not, but just they can have discogenic pain as well. So that is how it develops. So when you follow the concept of, it's called the tensegrity, which I'm sure many of you heard the concept, then you're not gonna only inject in the disc and fix these broken windows. You're gonna fix the windows, but you will also provide the cross bracing. So your target injections will be supraspinous ligaments, the facets, the iliolumbar ligaments, thoracolumbar fascia, and the muscle attachments, SI, and the back muscle attachments as well. You can use dextrose prolotherapy. I always say that's the poor doctor's PRP, but you can use fancy PRP or even fancier bone marrow concentrate. And you will have similar outcomes as Kirchner. And patients will love it. And I gotta say, you will love it. You will not get burnt out because you have so many patients, and I'm passionate about this. So to finish again, and that's the take-home message, I say stay away from steroids as much as possible, or consider the clinical scenario if it really truly makes sense. There is good level 1, but not enough evidence that PRP and bone marrow does work fantastic in the disc, and we need more studies. And if you please consider the biomechanics in the low back, in the neck, your success will be so much better. Thank you very much for your attention, and enjoy the rest of the conference.
I'm Dr. Stanley Lam, a musculoskeletal sport and pain physician from Hong Kong. It is my honor and pleasure to be invited by Professor Radha Toba to present to you in this regenerative medicine, spine and joints webinar series. And today I'm going to lecture ultrasound-guided intradiscal platelet-rich plasma and bone marrow aspirate concentrate injection techniques for lumbar and cervical spine discogenic pain. I have no financial conflict to disclose and would like to dedicate this lecture to the God, to my Father in the heaven, and to my wife, and to all my teachers, including those silent teachers, and to all my patients. According to Professor Bogdak of Australia, the 3 common causes of mechanical low back pain are lumbar facet, discogenic, and sacroiliac joint. We're not going to talk about the facet and sacroiliac joint. But let's take a look at the intervertebral discs. It consists of annular fibrosis and nuclear pulposus. They are the largest fibrocartilaginous joints in the body, which does not have blood supply. According to literature, any intradiscal procedures are carrying risks. The risk is about 0.15% per patient. So it's about 2 patients in 1,000 patients. It's not a low percentage. And remember, these joints, they do not have blood supply. So they have no protection to any source of the infection, be it exogenous or endogenous. So my advice is don't jump to treat disc immediately. Treat other pathologies first. And better to have MRIs before intradiscal injection. And if possible, get some blood tests before the procedure. And 30 minutes before the procedure, give a shot of intravenous or intramuscular antibiotics for coverage. And for those patients with poor immunity, for example, they are diabetic or smokers, don't inject the discs. In fact, these spondylodiscitis with epidural abscess are real complications to paraspinal injections. So my advice is safety, safety, safety to infinity. Look at the lumbar spine. When we do a flexion, we are opening the facets and we're transmitting or shifting the intradiscal pressure from anterior to posterior, which is reverse in extension if the disc is still intact. When we extend our lower back, we are closing the facet and we are shifting the intradiscal pressure from posterior to anterior. And we need to know the nerve supply to the disc. Posteriorly, the innervation is from the sinovertebral nerve, which are branched out from the ventral rami even before the spinal nerve root leave the neural foramen. Anteriorly, they are mainly supplied by nerves from the sympathetic trunk. So these are the nerve supply branch out from the sympathetic trunk. So that also supply the anterior longitudinal ligament. This is a typical mapping of the discogenic pain of the lumbar spine region. The L3-4 will be along the iliac crest. The L5-S1 is pretty much over the buttock cleft and also at the L5-S1 region. And the L4-5 is most extensive. The techniques I'm going to share with you today is basically to treat mainly the central posterior disc protrusion. We're not going to treat those patients already with herniation of the disc or the budding of the discs. The first paper we published in May last year was to treat with a patient lying prone, and the target is the Camping triangle, which is formed by the existing nerve root, the superior articular pillar, and the end plate. We're coming from posterior to anterior with the patient lying prone, and then we're targeting at the Camping triangle to get into the disc. The patient is lying prone. The needle is coming from posterior to anterior, lateral to medial. We are trying to hydrodissect. After passing through this intertransversarial ligament, we keep hydrodissecting our way in to push away the lumbar plexus, which is on the way to our Camping triangle. We can keep hydrodissecting with volume. Most of the time, we're using only 5% dextrose at this moment, trying to push away the nerve root. When we enter the Camping triangle, then we keep injecting and we turn 90 degrees and until our needle is inside the disc. This is one way of doing it. But in fact, not all patients can tolerate lying prone or they have phobia lying prone. Here we are going to introduce another technique which we published just this month. We have the patient lying sideways on the lateral decubitus position or the modified recovery position like this. You can use the QR code to get the paper. And the needle is coming lateral to medial, a little bit posterior to anterior. The needle entry point is over the iliac crest. We are pointing towards the annular fibrosis of the disc, having a steep angle. So when we line patient on the modified recovery position, when we scan the discs, and then you can see the L5-S1 disc is here, L4-5 and L3-4 and then L2-3. So you have the psoas, you have the lumbar plexus, and common iliac vein as well. This is when you look at the L3-4 disc. This is when you look at the L4-5 disc. This is the L5-S1 disc. So this is how you can approach that. When a patient is side lying, when you take a direct vertical fluoroscope view, which will be the side view of the patient, and you turn the fluoroscope to the sideway, you are doing an AP view of that disc. So this is the setting we are doing with the patient lying sideways. You're approaching using a biplanar validation of the needle placement. So a needle coming from lateral to medial, and you can see the whole trajectory of the needle very well. And when the needle has entered the annular fibrosis, you turn the probe 90 degrees, then you can see the needle inside the annular fibrosis. Then you do your injection. When you're injecting just outside the annular fibrosis, you can block the sympathetic supply to that disc. Then inside the disc, then you change to your platelet-rich plasma or bone marrow aspirate concentrate and then do the injection. So this is how you can have validation using your fluoroscope with the needle coming from lateral to medial and then with the patient side line. And this is another example of that. My 3 common causes of mechanical chronic neck pain: facet disc, neuromyofascial pain. Look at the cervical discs. We are treating posterior diffuse disc bulging, some broad-based protrusion. We're not treating those disc herniation or budding. And the group of patients usually they presenting with interscapular pain or pain radiating to upper limb. So we're not going to talk about how we do the anterior cervical spine scanning. We don't have time. We don't have time to do the ultrasound guided spurling test, but at least I want to share with you this rotation type of disc assessment so you can see some debris inside the disc are moving. So these are the signs you would like to see before you do a cervical intradiscal injection. So this is the longest coli with the longest catheters inserting onto that. So this is the right side of the patient, and this is the left side of the patient, and this is the disc, and the spinal cord is right here. So when you do a long axis scanning, you can see the disc having problem. It's narrowed and it's also having some debris when the patient is doing a rotation. You can do the flexion as well. When you have a patient presenting with interscapular pain, you have to be very careful that the interscapular pain can be 3-4, can be 4-5, can be 5-6, 6-7, or even 71. So you have to differentiate carefully the pattern of that pain and then also do your interdiscal assessment using dynamic musculoskeletal ultrasound. The patient is lying supine using a pillow to hyperextend the neck. Needle is coming from lateral to medial. Your needle is coming very, very close to the internal jugular vein, basically hydrodissecting and pushing away the internal jugular vein. There are 2 advantages to this. Number 1, when you push away the internal jugular vein, you will be very close to the carotid artery. Then you can have your needle with angle to pass away the uncovertebral joint, which will be obstructing your way to get into the disc. There is another advantage that when you're getting very close to the internal jugular vein, you are away from the cervical nerve roots. So you're hydrodissecting your way in, and at the point when you go to the sympathetic trunk, you can hydrodissect a bit to block or hydro-release the nerve supply to the cervical disc. When the whole trajectory has been seen inside the disc, you turn the transducer 90 degrees to validate your needle placement in the annular fibrosis. And you are seeing the needle at all times. This paper has been published in last year as well. And you can also validate the needle placement inside the disc by injecting dye and using the fluoroscopy. In summary, ultrasound-guided lumbar and cervical discs needle placements are feasible. Current reports showing that platelet-rich plasma and bone marrow aspirate concentrate are both effective, and it seems BMAC is slightly better. Usually, about 1 cc of injector is required per cervical disc, and less than 3 cc per lumbar disc. Further studies are needed to show which is the best and cost-effective regenerative solution. If you're interested in learning the technique I just shared with you, please join us in the end of June next year in our Fresh Cadaver workshop, which will be held in the Chinese University of Hong Kong. Thank you very much for your attention.
That was a great 2 talks there, Rita. I think both Agnes and Stanley gave great talks. I learned a lot from both of them. I can't believe the skill of ultrasound guidance that he possesses. That's amazing. And her talk on disc therapies was certainly very, I think, just really great building blocks for taking care of folks. So I think you're going to introduce our next speaker now, which I think will be an in-person speech. So we'll be able to ask some questions following that.
So amazing talks, and Dr. Jean Lee Pan is very well-known expert in the field of regenerative medicine and pain medicine. He is an attending physician department of physical medicine and rehabilitation in Taipei Medical University Hospital in Taiwan. He's the medical director of Pan Regenerative Pain Clinic. He's a well-known speaker, and he is director of the World Academy of Pain Medicine Ultrasonography, and we're very delighted to have him. So the podium is yours, Dr. Pan.
Thank you for inviting me. So today's talk would be on exosomes in future regenerative spine and joint interventions. And the question is, are exosomes a disruptive innovation in the process of doing regenerative pain medicine? So I have nothing to disclose. And as the pain physician, we see patients from spine and joint pain every day. And when I see the patient, we do the history taking, then we do physical exam, then we order some image study for differential diagnosis, and luckily enough, we can do ultrasound or other image-guided interventions. So that's the way we do now in every part of the world. And we're making progress every day, but we make progress from doing local tenderness to X-ray guided interventions. Then we move on to ultrasound guided. Then we do dual image guidance, just as Professor Stanley Lam has talked about intradiscal injections. But the question is, now we are facing a new waves for regenerative pain interventions. And this new wave is called exosome. So my job is to quickly give you a brief idea on what are exosomes, how are they different, and why should I care? So what are exosomes? Well, exosomes are one of the vesicles which were secreted by the cells. Almost every cell secretes vesicles, and exosomes are one of them. So we can see that on the bottom right, these are exosomes. And there are three hallmarks of exosomes. They have a bilayer membrane, which you can regard it as an envelope. And the bilayer membrane provides the exosome stability, and it protects the cargo from degradations, and they can move across biological barrier, especially blood-brain barrier, and they have adhesive proteins which can target their recipient cells. So you can regard this bilayer membrane as an envelope you are writing to mail. And the second hallmark of exosome are their surface markers. Okay, so they are CD9, CD63, and CD81, which we can identify as an ID of exosome. So using other immunofluorescence study for identifying exosomes. So you can regard the surface marker as the ID of exosomes. Then there are something inside the bilayer membrane we call the cargoes of exosomes. And these you can regard it as keys inside the envelope. So the keys can trigger or block the functions of the recipient cells. So what are these cargoes? Mainly, they are messenger RNA or microRNA inside them. So here's the surface marker. The surface marker can show you how they come from and where are they going to target. Then when the exosome approaching the target cell, the bilayer membrane can be absorbed by the target cell. And once they enter the target cell, they can change by either increasing, enhancing, or blocking some of the phenotypes or function of the cells. So this is how the exosome works. So they secrete from the stem cell or the donor cell, and they enter the target cell and change the function of the target cell. So what we are doing every day, for example, the PRP, many of the functions that PRP provide for tissue regeneration are from exosomes. So this is a very good example for that. So how do exosomes defect differently based on these basic study? We know that traditionally, when are doing every day, that the problem is well understood. We know that the a degenerative joint is from wear and tear, and now we know the subchondral bone plays a key role for that. And we also know that from kinetic chain, we know that there is biotensegrity system, which we can give a brand new view for dealing with musculoskeletal pain, even for nerve pain. We also know that the nerve-induced pain is not only from nerve injury, but also from a neurogenic inflammation. So this is all we can already know now. And the innovation comes from the initial prolotherapy, then migrate to PRP, and then the mainstream now is a cell-based treatment for regenerative pain interventions. And the last one, we know in the sustaining innovation model, that traditional business model shows that the more injection we can do, the more money we can make. So you can either do a solo practice to do competition, or you can do teamwork to dealing with the competition. But for exosomes, on the contrary, the problem is not well understood. So, for example, the trinity of tissue engineering, which can include the cells, scaffold, and signals. We know the trinity already, but with the emergence of exosomes, they are almost can replace where the cell can provide. So we don't know exactly when the cells are replaced by exosomes, what will be in the near future. So the problem is not well understood. And the innovation is dramatic and usually game-changing. For example, the exosome, because they have very, very few surface membrane proteins, so they have lower immunogenicity, which make them able to inject from allogenic sources. So this means that we can do it from a personal medicine model to a mass production model. So with the allogenic exosomes, we can use the exosome as a drug rather than only medical procedures. So that would be game-changing. And we also know that these exosomes can carry drugs in the cargos, and they cross the blood-brain barrier. In this way, that in the near future, maybe exosomes can deal with some central pain, which was not able for us to intervene at this moment. So this is also game-changing. And in tendinopathy, which George has mentioned in the previous great talk, that exosomes has been shown, at least in vitro, they show that they provide higher quality of healing compared to other mode of regenerations. So this also, we are expecting the exosomes can play in the near future. So these are game-changing properties of exosomes are really dramatic, especially this homing effect. I'll deliberate this later. And the most important of exosome is we can edit them. We can edit them from the surface. We can edit them from inside the cargo, so we can make our custom-made exosomes for our clinical use. So we can add some drug inside it. We can add the surface marker. We can add some proteins on that to improve our delivery, to add our drug inside that, to enhance our clinical effects. So this is something we can do for PRP and for cell-based interventions. So this example shows that engineered exosomes can carry our drugs into the bloodstream and cross the blood-brain barrier and into the central nervous system. And the people don't exactly know which exosome is the best. So there are PRP exosomes, there are MSC exosomes. We even have iPSC exosomes. We don't know now which one is the best for our pain patients. And the business model, as I said, we use images to guide our pain interventions for our daily practice. But as I said before, that the homing effect of exosomes can lead our treatment to a target cells, which means that we can do a non-specific delivery, for example, the IV drip of the exosomes, but the result will be specific. So that's quite different because with exosomes, we don't need to guide very, very accurate to our target. They can find the target by themselves. So is this a challenge or threat for image-guided pain physicians? So this is really brain-blowing idea with the exosomes. They are game changers. They may be quite different in our future pain practice. So with the exosomes emergence, next time we see our pain patient with spine joint pain, maybe we can start with also history taking, but maybe we will shift to exosomes bioassay because we call a fluid biopsy, we can know exactly or immediately what's the problem of the patients. And then we jump to IV drip of exosomes rather than image-guided interventions. So that's quite different, right? So the conclusions, or I shall make it more accurate, the question is, will these bubbles of exosomes be just a sparkling, beautiful, but doesn't harm for us, or they are really nucleotides, but we can control them very smoothly, or for our pain physicians with image guidance, these exosomes will be a tsunami that will destroy everything we are familiar with. I don't have the answer, but the only thing I'm sure that we have to think out of the box with the emergence of exosomes.
Dr. Pan, that was
attention.
Great job. I just have one quick question for you. So I think this is the most exciting part to me of regenerative medicine. I think the potential here is crazy good. But what is the risk? What can make this fail? Because it seems like it's going to change everything. What is the risk out there that would make this fail and not be a game changer for us all?
Right. There's a really risk for using exosome. For example, there are some virus infection which can be faked as exosomes. We know that there are similarities between viruses and exosomes. And some cells, when they are infected by a virus, the genome, the genetic components can be hidden inside the exosomes, which will not be detected by a traditional way of clinical assay. So that would be a major risk of using exosomes. Yeah.
So thanks. That's frightening. I didn't know that. Thank you so much.
Thank you so much, Dr. Pan. And as being a world expert on this, where do you think is the, if you were from the pain standpoint, where is the most important future study need to be in on this?
I think that there are a lot of things to be done because we see the trend, but we are still in the baby stage of using exosomes. So I think it will take about 3 to 5 years at least to know how we can harness the exosome to be a positive way in doing regenerative pain interventions. Yeah.
Thank you.
Thank you.
Definitely very, I'm learning a lot from this webinar. Very, very good lecture, Dr. Pan. And thank you for being here with us.
Thank you.
We'll move on to our last lecturer, Dr. Abdallah Alam. Dr. Abdallah Alam is he's a practicing pain physician and physical medicine and rehabilitation specialist from Tanta University in Egypt. He's the co-founder and instructor of the Egyptian Society of MSK, Musculoskeletal and Neuromuscular Sonography. And he has a lot of experience in regenerative medicine. And Dr. Abdallah, please, it's all yours. Go ahead.
Thank you very much for your kind invitation. My pleasure to join your well-distinguished international faculty. I will talk about a large muscle tear in gastrocnemius. My patient is male, 45 years old, police officer, suffer from trauma with large tear in the medial head of gastrocnemius since January 2021. And presented, you can see here the swelling and subcutaneous edema. The marks of the bandage on his leg are apparent in comparison to the other side. Patient presented to the ultrasound unit by March 2021, and you can see here the large tear in the medial head of gastrocnemius with hematoma inside. Okay, this is a video for the tear. My plan is to do hydrodissection of the sural nerve by glucose 5% to relieve the pain, and hydrodissection of tibial nerve to improve the muscle power and regeneration. I did then ultrasound guided aspiration of the intraregional hematoma. Then I injected under ultrasound guidance growth factors and hyaluronic acid combo through upper, middle, and distal parts of the tear, followed by bandage. Here I do hydrodissection, dextrose, deep perineural injection of dextrose water around sural nerve. Let's see. The next slide is deep perineural injection into around the tibial nerve. This the needle target short axis view of the tibial nerve at a level higher than the tear. Aspiration of the hematoma. Now this is how I prepare the growth factor hyaluronic acid combo. We have a powder of growth factors containing epidermal growth factor, transforming growth factor beta, platelet derived growth factor, and fibroblast growth factor. We dilute it with distilled water, aspirate the powder. Now this is the growth factor, diluted growth factor. Then I aspirate the hyaluronic acid. So we have the growth factor hyaluronic acid combo ready for injection. Here after injection, you can see upper injection into the upper part, into the middle part, and into the distal part of the tear. And you can see the videos. Here I inject into the upper part of the tear where there is cells, muscle cells, many muscle cells at this part. Spread of the material of the growth factor and hyaluronic acid. Next, please. Here, injection into the middle part, short axis view of the middle part, and I inject. Next, please. Then injection into the distal part. Then bandage to approximate the edges of the muscle after injection of the regenerative combo. Now this the presentation to my department. You can see the swelling and subcutaneous edema after the intervention at 5th of April. You can see here the contour of the muscle is reduced and restored, and there is no subcutaneous edema. Next, you can see more or less more normal contour of the medial part of the gastrocnemius, and no edema at all in comparison to the other side. Still larger to in comparison to the other side, but okay, more or less it is reducing the size to the normal. Next, please. These are the long axis view of ultrasound images at the middle of March, early April, and early May. You can see more regeneration and more healing and more remodeling toward muscle fiber formation after failed conservative treatment by orthopedic and vascular surgeons for 3 months. I allow the patient to do first non-weight bearing active range of motion exercises in bed, followed by gradual resistive exercises. Next, please. This is the short axis of the widest area of the tear. You can see here the hematoma and muscle septum here. Now this at the early May, you can see formation of muscle fibers and repair, and there is no gaps at all. And the officer returned to his work 100%. Next, please. Regarding the discussion, tears of medial head of gastrocnemius. Tears of medial head of gastrocnemius are common clinical condition misnamed as tennis leg and commonly involve young athletes, but middle-aged or older patients above age of 40 might be involved. The mechanism of tear is related to extension of the knee with simultaneous forced dorsiflexion of the foot, and the healing might take from 16 weeks, around 16 weeks, and the mean duration of healing of tennis leg is 27 months. Athletes should rest for from 4 to 12 weeks before return to sport activity. The role of ultrasound is to determine the stage of healing and the process of healing and resorption of hematoma, and the healing is started from periphery toward the middle with successful tear. So ultrasound is important for diagnosis and follow-up of the repair before decision to return to work or sport activity. This figure represents the stages of healing of the muscle tear, and in this module, you can clarify the role of growth factors at each stage I will discuss later. In this article published by Professor Stanley and his colleagues, he focused on role of nerve supply to different structures like tendons, ligaments, muscles, and the role of neurogenic inflammation in mediation of pain, tenderness, swelling, and delayed healing. And on hydrodissection, you will have improvement of the pain, swelling, tenderness, and improvement of the repair. And here is the supposed mechanism of hydrodissection: modulation of TRPV1 receptors, hyperpolarization of C fibers, reduction of the firing rate, potential analgesic effect, energy supply to malnourished nerve, release of the nerve from mechanical dissection, mechanical compression after swelling, and the increase of pressure inside the affected compartment. The result of nerve hydrodissection is reduction of pain, remodeling and healing, improvement of proprioception, restoration of the muscle power, and the restoration of stability and the pain-free range of motion in ligament injuries. Regarding growth factors, many growth factors are involved in the process of the muscle repair, like insulin growth factor 1, vascular and cellular growth factor, fibroblast growth factor, transforming growth factor beta, platelet derived growth factor, which are present. Most of them were present in the powder that I used in the treatment of my patient. And these growth factors work through binding to specific receptors with phosphorylation and activation of intermediate signals, so stimulate DNA and mRNA synthesis and expression of proteins and the mediators that stimulate the muscles and the connective tissue, stroma repair, and restoration of the muscle mass and strength. Regarding hyaluronic acid in muscle tears, hyaluronic acid was extensively found in epimysium, perimysium, and endomysium, and the injection of hyaluronic acid stimulates proteoglycan synthesis, providing supportive stroma for the repaired muscle. Regarding the exercise therapy, gradual exercise therapy after the program, according to wall flow, tissues remodel according to stress placed upon it. So don't do the intervention forgetting combination with rehabilitation. Rehabilitation together with the intervention will result in optimization of the clinical and the patient outcomes. Next, please. Take-home message is good knowledge of the anatomy, underlying pathology, role of the growth factors, pharmacogenomics, rehabilitation. This multidisciplinary approach will improve results of the regenerative intervention. And thank you very much.
Thank you so much, Dr. Alam. That was a very fascinating topic, and you obviously have a very high understanding of this. For those of us that don't have a lot of experience in this, when this appears to be the future, again, for, we all, I think in our specialty, want to focus on non-operative treatments. In your experience, for these muscle tears, which regions of the body have you had the most success with this type of strategy?
I treated in my practice 3 types of patients: non-sport and sport, and the sport patient either induced the injury by himself. I have a patient with injection of paraffin oil into his muscles. He is a bodybuilder and injects paraffin in his muscles, and paraffin induced muscle fibrosis. And I did also hydrodissection of the nerve supply of biceps and triceps with percutaneous needle myotomy and injection of platelet-rich plasma in one patient, and another patient growth factors. The other patients I treated is biceps, femoris tear, and gastrocnemius tears. So this approach is very effective in those types of patients because the cost of the intervention, patient by his own pockets the hyaluronic acid and the growth factors which are imported outside Egypt. Not all patients can pay for this intervention. So I have only 6 patients, and they were successful, and they were returned to their sport or activities of daily living completely after the intervention within 1 or 2 months maximum.
Thank you very much. Rita?
Yes, thank you, Dr. Alam. This was a very fascinating topic, and I think we were a little bit over time, but I think thank you so much, all our faculty here for being here with us. All the presentation were fantastic. Thank you, the audience. We have, I think, a lot of audience from different parts of the world who attended the webinar, and we will have our webinar recorded, as Dr. Said and Dr. Deer said, over the website. So you can feel free to see the recording and learn from it. And we're looking forward to have future webinars and invite you over, hopefully, by next year to have a physical meeting and have people from different parts to learn and share knowledge and to serve the mission of I-ASPN. Thank you, everyone.
Thank you so, thank you so much. Thank you, everybody.
Bye-bye.
Just a few quick announcements. That previous slide, we do have a date set for our next international webinar, which will be focused on neuromodulation. And then in the fall, we'll have our 3rd webinar, which will be focused on radiofrequency ablation. And as Rita mentioned, we're really gearing this all towards our first in-person I-ASPN meeting, hopefully in Dubai. So hopefully you guys will all join us there. I think it's going to be fantastic. Prior to that, of course, we're going to have our ASPN annual meeting in July 22nd through 25th. We'll have live streaming options for international members who can't make it because of the pandemic, but those of you that can travel, we welcome. We'll have a large contingent of in-person component to the meeting. So thank you, everybody, and looking forward to seeing you all again in the future.
Thank you very much.
Thank you.
See you. Bye.
Thank you, everybody.
Bye-bye.
Bye.